You would think a body difference would announce itself, a curve, a dip, one side working differently. But the mind does not inspect the body like a scan. It learns a familiar baseline. If a difference has been there for years, causes little trouble, and the body works around it, it may fade into normal. Some are true deformities. Others are developmental differences or anatomical variants. They are not equally common, and different does not automatically mean damaged. The real question is, why can the mind miss something it has lived with the whole time? Deviated septum. Start with something you cannot easily see: the wall inside your nose. A deviated nasal septum means the cartilage and bone wall between the two nasal passages sits off-center. From the outside, your nose may look ordinary. You might simply grow up thinking, yeah, this nostril is the bad one, especially during exercise, colds, allergies, or at night. This can hide because the signal is private and relative. You are not comparing your airflow with some perfect factory setting. You are comparing it with the airflow you have always had. That matters. The mind is very sensitive to change, but it is less dramatic about stable conditions. A long-standing pattern can become part of the background because there was never a clear before and after moment to make it stand out. A deviation can be developmental or follow an injury. Some cause almost no trouble. Others can contribute to persistent obstruction or related symptoms. But unequal airflow is not proof of a deviated septum. Swelling, infection, allergies, and the normal nasal cycle can all change which side feels more open. So the point is not blocked nostril equals hidden deformity. The point is that a body signal can feel normal, simply because it has always been your normal. Mild scoliosis. Now take a difference you technically can see, but not directly. Mild scoliosis can be easy to miss. One shoulder may sit a little higher. A shirt twists. One side of the waist looks slightly different. A backpack strap keeps sliding off the same shoulder, and you blame the backpack because, honestly, that is a strong suspect. Clinically, scoliosis is more than ordinary slouching. It is a three-dimensional spinal deformity, typically confirmed on imaging with a Cobb angle of at least about 10 degrees. The psychological reason it can go unnoticed is different from the septum. This is not mainly about a private internal signal. It is about access. You do not see your own back the way other people see it. You see mirrors, photographs, clothing, shadows, and whatever angle your bathroom lighting has decided to provide. Then your mind stitches those fragments into a general sense of what I look like. That sense can be useful without being precise. A stable asymmetry can therefore be visible in pictures and still not become important in awareness. The mind is built to detect meaningful change, not to audit every shoulder height every morning like it works for quality control. So a person can know their body, recognize themselves in a mirror, and still not know the shape has a clinical name. Pectus Excavatum. Now move to the chest, where the issue is not just access, it is identity. Pectus excavatum is a chest wall difference in which the breastbone sits farther inward than usual, creating a sunken area in the center of the chest. In pronounced cases, it is obvious. In mild cases, someone may simply think, that is my chest. Maybe it has looked that way since childhood. Maybe posture or body build makes it less noticeable. Maybe nobody ever gave the shape a name. This is a third kind of invisibility, the self-template. The mind does not learn the body from a population chart. It learns from repeated ownership. The body you grew up with becomes the reference image. Not because it is average, because it is yours. That is why naming can feel strangely powerful. Before the label, the shape is just part of the room you live in. After the label, the same shape becomes an object you can compare, search, worry about, or explain. Many mild cases cause little or no functional trouble. In more pronounced cases, the depressed chest wall can compress or displace structures inside the chest in some people, and symptoms such as reduced exercise tolerance, chest discomfort, or breathing difficulty deserve proper evaluation. But psychologically, pectus can go unnoticed because the mind does not experience your body as a category, it experiences it as home. Leg length discrepancy. The next difference hides in movement. A leg length discrepancy means the two legs are not exactly the same functional or structural length. Sometimes the bones themselves differ. In other cases, the apparent difference is related more to alignment, joint position, pelvic position, or how the surrounding structures are working. A small discrepancy may show up as one shoe wearing differently, a slight pelvic tilt, one knee staying a little more bent, or a habit of standing on the same side. Here, the mind is not simply ignoring the body. The movement system is solving a problem. Your nervous system maintains practical maps of the body for balance, walking, turning, and reaching. These maps are not anatomy diagrams. They are operating instructions. So if one side is slightly different, the body may adjust around it. The pelvis tilts a little, the knee softens, the foot lands differently. The person keeps walking. And because walking still works, the difference may disappear inside the solution. That does not mean every compensation is harmless, and it does not mean every uneven stance comes from leg length. It means function can hide structure. You can be different on paper and feel normal in motion. Flexible flat feet. Feet create another kind of mistake, confusing appearance with dysfunction. Flexible flat feet are feet in which the arch looks low or absent during weight bearing, but may reappear when the foot is unloaded or positioned differently. A person can have this for years without caring. Their footprints look broad, shoes lean inward. Someone eventually says, "You have flat feet," and they look down as if the feet have been keeping secrets. Many flexible flat feet are painless. That matters because the mind likes simple visual categories: high arch, normal, low arch, problem. But anatomy is not that cooperative. A shape can differ from the mental prototype and still work perfectly well. This is why appearance can mislead in both directions. A foot can look different and cause no problem. A foot can look ordinary and still hurt. The visible shape is only one clue, not the whole story. The useful question is not just, does this foot look flat? It is there persistent pain, limitation, stiffness, or another functional problem? Sometimes the reason you never noticed a difference is not that the mind missed a warning sign. There may not have been a warning sign worth noticing. Clinodactyly. Sometimes the difference is visible, works perfectly well, and still barely enters awareness. Look at your little fingers. One may curve slightly toward the ring finger. If that curve has always been there, you may have noticed it without ever treating it as information. A congenital sideways curvature of a finger is called clinodactyly, most often affecting the little finger. Mild curvature is generally considered a minor structural variation, and many cases do not interfere with hand function. The psychological blind spot here is selective comparison. You use your fingers constantly, but you rarely compare their exact angles with a population template. The hand closes, the phone stays in it. The jar eventually opens after a brief dispute. Function gives attention very little reason to investigate shape. That is different from failing to see the curve. You may see it clearly. It simply never becomes important enough to ask whether it has a name. When curvature is pronounced or limits movement, it can matter clinically, but a mildly bent little finger by itself does not reveal a diagnosis, a syndrome, or a hidden chain of problems. Sometimes the mind misses a body difference not because it is hidden, but because nothing about it demands an explanation. Spina bifida occulta. A quiet visual difference can stay ordinary for years. A medical name can create the opposite problem. The next example shows how much a name can distort expectation before a person even understands what it means. Spina bifida occulta sounds severe because most people hear the first two words and mentally complete the category. But occulta refers to a hidden form involving incomplete closure of part of one or more vertebrae, often in the lower spine. Many people with uncomplicated forms have no obvious symptoms and may discover it only on imaging. It is not the same thing as the more severe forms of spina bifida involving major neural tissue abnormalities. Psychologically, this is a category shortcut. The mind does not wait calmly for the full medical explanation. It grabs the most familiar or frightening version of the category, then tries to fit the new information into that shape. The name arrives first. Nuance has to catch up later, usually out of breath. That is why careful explanation matters. A condition can share a family name without sharing the same severity, symptoms, or implications. And, of course, often silent does not mean always irrelevant. Neurological symptoms, progressive weakness, bladder or bowel changes, or other concerning signs deserve proper medical assessment. Lumbosacral transitional vertebra. Now for a difference you may never feel because there is almost nothing ordinary awareness can feel. A lumbosacral transitional vertebra is a vertebra at the border of the lower back and sacrum that has features of both regions. The lowest lumbar vertebra may partly join the sacrum, or the upper sacral segment may look more lumbar than expected. For many people, this is simply anatomy. Some forms have been associated with low back pain, but the relationship is not a simple rule that variant equals symptom. The reason it can stay hidden is very plain. Conscious body awareness is useful, not complete. You can feel pain, pressure, movement, stiffness, balance, and position. You do not normally feel how your vertebrae are numbered. Nobody stands up in the morning and thinks, "Interesting, my L5 has transitional morphology today." If they do, they may need a more exciting breakfast. Your nervous system gives you action-relevant signals, not a labeled blueprint. That becomes important in a different setting: procedures and surgery. When the spine does not follow the most familiar pattern, careful vertebral numbering matters because the correct anatomical level has to be identified. So this kind of difference can be silent in ordinary life and highly relevant when precision suddenly matters. Cervical rib. One final difference shows what can happen when an invisible structure suddenly receives a name. A cervical rib can turn a quiet anatomical finding into a very loud explanation. Some people have a cervical rib, an extra rib arising from the lower neck region. That sounds like something you should notice immediately. In reality, a rib is not a notification system. If it causes no symptoms, there may be no reason to know it exists until an X-ray or scan happens for something else. In a minority of cases, depending on the surrounding anatomy, a cervical rib can contribute to compression of nearby nerves or blood vessels in the thoracic outlet region. That may be associated with arm pain, tingling, weakness, or circulation changes. But before a scan, the anatomy is invisible. After a scan, the named finding can become psychologically loud. Suddenly, every ache wants to belong to the extra rib. That is not how causation works. The same symptom can have many causes, and an anatomical finding can be an innocent bystander. Discovering a difference and proving that it explains a symptom are two separate jobs. The mind likes causes. It likes clean arrows. This thing exists, therefore this thing explains the discomfort. Medicine is usually less tidy than that, which is rude, but important. That is the thread through all of them. You know your body through sensation, movement, vision, and change, not through a complete anatomical map. A difference can stay hidden because it was always there, because you cannot see it directly, or because the body found a workable way around it. This is poor material for self-diagnosis. Bodies are asymmetrical, and symptoms are not one-to-one clues. You may have a structural difference you never noticed, not because your body is secretly broken, but because the mind gives you something more useful than a blueprint, a body familiar enough to live in, until one detail becomes impossible to ignore.